Dr. Susan Brace and several other folks today. I'm going to let them introduce themselves. Thank you very much. You're talking about working with veterans with traumatic brain injuries and kids.
I am.
Wonderful. Thank you.
Thank you. Well, I want to thank Deb Martin, who I know isn't here, but she did a lot of posting stuff online for me and a lot of phone calls back and forth. And Justin, I sent you a huge packet that I think you put online. Thank you. All of the notes, all kinds of extra neuroscience readings are online. You don't have to take any notes. Okay? And if you have questions, just word them out. That's fine. And the reason I put all those neuroscience articles, by the way, they're all in English and not science, so that they're easy to read, is because neuroscience is exploding right now with research, and it's all kind of basic research, but in the next 10 to 15 years, it's going to change the face of what we do. And then we have a special set of guests today, and they are sitting over here. This would be Judy and Susan and Posey, and they're from Freedom Service Dogs. And how this is going to work is I'm going to talk about brain injury first. Then I'm going to let them have a stage and show you what a dog can do, because I am very, very much in favor of getting traumatic brain injury patients and PTSD patients a dog to help them, because they're very useful. And then we'll take a break, and then we'll do post-traumatic stress disorder, and I am going to veer off the outline for reasons I will explain later. I might lose my license for this one, but okay. Okay, so what we call this is insights and interventions to access and treat clients with traumatic brain injury and post-traumatic stress. Okay, now I'm going to speak to you as a nurse. Okay, I had 9 years in medical intensive care, taking care of cardiovascular and neurological accidents. Okay, so what I'm going to do is give you a lot of background, because when people say, well, how can you treat traumatic brain injury? Unless you know what it is, you can't treat it. So it's very complicated. And I'm going to speak now not just about soldiers, but about civilians as well. Okay, the CDC estimates that in the United States, 52,000 people die a year of a traumatic brain injury. Okay, in addition, 275,000 are hospitalized with a traumatic brain injury, and falls are the leading cause. The highest rates of falls are between 0 and 4 years of age, and above 75 years of age. Motor vehicle-related injuries, those kinds of accidents, are the second most common cause of traumatic brain injury, and the leading cause of traumatic brain injury deaths related to adults between the ages of 20 and 24. All TBI rates in every category are higher for males and females, and about 75% of TBIs are concussions, or another form of mild TBI. Okay, what's a concussion? Well, it's transient. It's reversible. It's a post-traumatic alteration in mental status that includes level of consciousness and things like memory. And a concussion is only supposed to last a couple minutes. And there is another set of criteria where it lasts less than 6 hours, if you want to call it moderate to mild. Okay, so when somebody says to you, you say, did you lose consciousness? And they say, no, I saw stars. They lost consciousness, maybe for just a couple seconds. The Army is no longer asking soldiers if they lost consciousness when they were blown off their Humvee, because they lied. Warrior culture, I am invulnerable. So they ask everyone else, did he lose consciousness? Okay? What's happened is a lot of the guys that have already come back have said, no, I didn't. And so there's no medical record when they're in the service. And so then they come and they clearly have a brain injury, but the way they're behaving, but they can't keep their job, their marriage is falling apart, they have a little PTSD, but they're doing something weird. And there's no record. Or if you get someone in special ops, there's no record. You know, they look like they were in the kitchen somewhere in Kansas and they but those guys have a real problem. It's Navy SEALs, Special Forces, they can't tell you where they were. So there's no record. And that's a problem. Okay, so the most common causes of traumatic brain injury: falls, motor vehicle accidents, and violence, including gunshot wounds. If you were listening, and it has one of the highest rates of gun control. So what's going on there? Okay, now I'm going to start cutting the pie, and I'm going to cut it in all different ways. TBIs are classified as penetrating, open head, and non-penetrating. You whack your head against the front of the car and then against the headrest, but it doesn't break the skull. And then there's a focal traumatic brain injury where there's a contusion, that's a bruise, and a hematoma, that's a place where it bleeds, you know, that's a hematoma. Somebody drew my blood and messed it up. So I have a hematomator right there. Okay, and then there's a diffuse injury. And now this is the new research that's coming out from the VA. And a DAI, a diffuse axonal injury. I'm not even going to go into what that is and how dangerous it is. The Department of Defense and the Department of Veterans Affairs define a TBI as a traumatically induced structural injury to the brain. Okay, and or a physiologic, not a psychological, physiologic disruption of brain function. Okay, it's the result of external force, and it is indicated by a new onset or a worsening of at least one of the following clinical signs: a period of loss or decreased level of consciousness, any loss of memory for events immediately before or after the injury, any alteration of mental state at the time of the injury, confusion, disorientation, slow thinking, and then any of the following neurological deficits: weakness, okay, loss of balance, visual changes, and those are kind of cool. Visual changes can be, you can see the top half of the field, not the bottom. You can see the right side of the field, not the left. You can see, you may ignore everything on this side and only look at this side and not even know this exists. You can go blind for a period of time, bless you. You can just have fuzz and not see clearly. There's all sorts of things that can happen in the visual field. You can have sensory changes, like the gentleman with a head injury right now who smells cigarette smoke under his nose. And we finally got that after sending him from doctor to doctor to doctor. It's a seizure. You can have paresis, which is partial paralysis, and a part of your body. It can be a hand, an arm, it can be the whole side. You can have plegia, which is paralysis. You can have aphasia, and that's a language disorder. And you can have receptive aphasia, which means when I'm receiving a message, it comes in garbled. You ask me, do I have shoulder pain? And I hear, how is you? Or it can be expressive. I try to tell you I have shoulder pain, but instead I say, how is you? Okay. You see that a lot after a cardiovascular accident and stroke. And sometimes it gets better and sometimes it doesn't. Okay. Now, a TBI can also be stratified another way, and that's by mild, meaning that a mental status change or loss of consciousness is less than 30 minutes. It can be moderate, 30 minutes to 6 hours, and then it's severe. It's more than 6 hours and these people die. Or they're left on life support, they go into a coma, and they're removed from life support at some point. If they show no, we do test for brain function. We don't just knock off somebody's life support. But what happens with severe is under emergency neurologic life support, and the guidelines say that the unconscious patient has to have an identified mechanism of injury consistent with a head injury, and a Glasgow coma scale, and I'm going to talk about that in a minute, of 9, which is low. It means that they're not following directions, they're not winking, they're not squeezing your hand, they're not moving all fours, they're decerebrate or decorticated. When you're trying to figure out, here's a comatose patient, what level of brain function do they have, you inflict pain. Okay, usually put a pencil on your thumbnail and close it. And if they do this, okay, in the ICU, it's one thing, it's decerebrate, and if they do this, it's decorticated. Okay, and that's a lower level of brain function. And those folks sometimes wake up, sometimes they don't. Okay, now at the time of injury or accident, you have what we call the primary brain injury. And this can be a penetrating or open head injury. And it penetrates both the skull and the brain. Or you can have a direct impact. Okay, so you're driving along 285 at 300 miles an hour, and you hit an abutment, here's what happens. If you don't rip your heart off your aorta and die right then, your brain will slam into the front of your skull. That's the acceleration or the coup injury. And then it slams into the back of your skull, which is the contra coup or deceleration injury. So you get a big bruise here and a big bruise here inside your skull. Your brain bleeds. Okay. Now, when it's severe, this kind of a direct impact is fatal. Okay. In a closed head, non-penetrating injury, where you have both the coup contra coup injury, you have what we now have found out from our veterans, another kind of injury. And this is called a shearing of the neurovascular structures or a rotational injury. And what this means is, here's your brain, here's your cord, it does that. It torques. And when it torques, it tears neurons. We used to think that neurons didn't rebuild themselves, but we know that they do. But this is a diffuse axonal injury. And the problem with this is it doesn't show in CAT scan. And it doesn't show on an MRI. And it doesn't show on an x-ray. And oftentimes, when the axons are torn, there are reasons I'll get into, but they leak. And they don't repair themselves back to back so that you have that bridge. They do that. And then you have someone whose head injury is not going to get better, except if you build new pathways, which we will talk about. Okay, so a rotational injury most often occurs in some kind of a pressure wave injury, you know, you were blown off their Humvee 30 feet and landed over there. A guy that was blown out of a helicopter and landed on the other side's rocks with a broken back and a terrible head injury, which he still has today. All right, so in a high-speed collision, you get the coup, the contra coup, and then the rotation. Okay, and when you shear, oftentimes it shears right at the connection of the white matter and the gray matter, which isn't good. Now, that's going to be hard to get back together. Most lesions are severe in the corpus callosum. Okay, in your brain you have a hemisphere here and a hemisphere here, and they do different things. And underneath these hemispheres, there's a piece of tissue that looks like that, right here. Okay, that's your corpus callosum. And it is the superhighway between the hemispheres. Okay, if you tear the corpus callosum, what's going to happen in a very bad tear is you're going to go into a persistent vegetative state. Years and years of coma. What happens in a severe DAI is that, because you can't find it, people progress from severe DAI to severe encephalopathy, which is a progressive degeneration of the brain, and they usually die. Okay, in an open head or penetrating injury, a primary injury is caused by the foreign object, and it can be high velocity, we're talking bullets, shrapnel, or it can be low velocity, like a knife or a crowbar or something that whacks in and it's open head, so it breaks your skull. In a way that's kind of good, and your brain has a place to swell. Okay. So the neurologic deterioration occurs after a primary brain injury, has to do with competition for space. Here's this brain case, and it is solid. There is no room to swell. So on one case I had as a nurse, a woman came in and she had been beaten to death. She would die. And her head was as big as a basketball. And brains were coming out her nose, and brains were coming out her ears. And because of her religious preference, we couldn't give her any blood, and she was bleeding in there. So we couldn't do any surgery, and she died that night. Okay, and that's because she swelled up. And when you swell up in here, there's one other place your brain can come out, and it's very, very bad, and that's at the bottom of your skull. There's a hole about that big, and it's where your brain stem and spinal cord meet. And if you put a lot of pressure in here, it will come out your eyes, it will come out your ears, and it will herniate down into your brainstem. And herniation, you can't, when somebody starts, they're done. Okay, it happens really quickly. 80% of the space in your skull is taken up by brain tissue, 10% by blood and cerebrospinal fluid, and 10% is space. So you don't have much room to swell. Okay, here's what happens when you start to swell in there. You get intracranial pressure that increases, and then it pushes the blood vessels closed. Brain tissue starts to come out, and it's boom, 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 and it happens in about 20 minutes. Boom, boom, boom. I mean, I have been on the other end of a gurney running somebody into an OR trying to get that, open the skull and relieve the pressure, but that's pretty late in the game. Now there are secondary injuries, and they begin immediately after the bullet or the knife. Okay, and they continue for many hours or days, and they are far more lethal. Okay, and they are injuries that are a process. They're not just one stab wound or one bullet. Okay, and it can be very difficult to treat them. And a secondary injury is associated with a much higher mortality and morbidity. So if you evac a guy off the field with a gunshot wound to his head, okay, he probably will die in the medevac. But if he doesn't, then they'll do brain surgery. Okay, now the leading contributors to secondary brain injuries are hypoxia, which is nursing talk for lack of oxygen. When you squeeze the blood vessels closed because there's no room there, no oxygen gets beyond that point. When no oxygen gets beyond that point, the tissue begins to die. If you break a blood vessel and it bleeds into the brain tissue, it's very toxic to brain tissue. And no blood goes beyond there, so that part of the brain begins to die. Depending upon what part dies, that's the kind of symptoms you see. So you have to know where the injury was and what kind of injury it was. And then the other thing is the hypoperfusion, which is decreased oxygenated blood to the brain. And that also comes from swelling. You can't perfuse oxygen to the brain. And the brain, remember, in CPR, you have 6 minutes. Okay? If you don't get oxygen to that brain in 6 minutes, it starts to die. And then when you get somebody back, and this even in a hospital, you get somebody back, they're not right. Okay? Just for your information. Okay, if you show a low blood pressure in the first 48 hours of being in a neurointensive care unit, you probably die. That's a very profound sign. And so we do all kinds of things. We want to stop, we put you in a coma. If you're not in one, we put you in one. Then we put you on an ice bed with an ice blanket and drop your body temperature. We fill iced saline into your belly. We want you to get cold because then your tissues won't use so much oxygen and we can put it into the brain. We can also drop the oxygen and increase the CO2 to drop down the metabolism in your brain. And we can monitor the swelling in the brain. We can stick something in there and monitor, and it's pretty safe. Didn't used to be, but it is now. Okay, so there's one other thing that happens with brain injuries, and that's when you tear cell walls. Cell walls are little factories, and they have like sodium pumps and all kinds of ionic pumps, calcium pumps, and they're moving ions in and out of the cell. Well, when you tear those, like when you tear an axon, what happens is all that stuff leaks out into the tissue, and that's harmful. It sets up a cascade that ends up in a toxic substance in the brain. So you can see that once that bullet enters the brain or that knife enters the brain, something much more horrible is going to happen. And then, of course, there is the problem of infection. You like to think that the guy that stabs you with the knife has sterilized it before he puts it in there. But it doesn't happen, and then you get a really bad brain infection. And since this is the main organ and everything else is helper, you're in big trouble. Okay, so now I'm going to talk to you about indicators, and these are the things you're going to look for. If someone doesn't tell you, or if they say, no, I was fine in that accident, just absolutely fine. Okay, sometimes self-reporting isn't really good, especially if they can't remember. So this is something that you need to know. Okay, the first stuff is really medical indicators, physical signs, headaches, disturbed sleep, dizziness. Now, you can find out, maybe guy has an ear infection. So you have to rule this stuff out. But balance problems, people stumbling and falling when they used to. Nausea and vomiting, that's usually an early sign. When you get pressure in your head, you throw up. Fatigue, that's something I see in a lot of my veterans, is huge fatigue. And one of the things I tell people with brain injuries is sleep. Okay, Visual disturbances, and then photophobia, sensitive to light. These kinds of lights drive them crazy. So I turn off my lights when I come into my office, especially if they're flickering. And then tinnitus, ringing in the ears. Now you can get tinnitus if you are by a loud noise, but a loud noise is going to be a bullet in your head. It's going to be very loud, and then you might have ringing in your ears the rest of your life. And there isn't anything you can do about that. That's just is. Okay, cognitive symptoms. You are going to see these if someone has had a head injury. I had a very sweet lady who was driving her car with her husband down a country road, and they looked up and they saw an 18-wheeler coming on its side to them. And they had about 3 seconds to think about this. And they drove their little vehicle into a ditch, and then the truck crushed it. Men had backed out. Okay, so I saw her. Very slow thinking, okay, word searching, decrease in communication skills, memory problems around the incident and after, okay, poor concentration. This is what's going to get you in trouble at work, okay, and inappropriate speech, swearing when there's something to swear about in an inappropriate place. Okay, the emotional symptoms, and these are comorbid symptoms: anxiety, depression, irritability is a huge one. Migraine-injured guys have such road rage, and they think about killing people, and they all have guns, and so there's another sort of, when you treat, there's another risk here you have to assess for, which is not just suicidality, but homicidality. Mood swings, very low self-esteem. After all, they've come out of the warrior culture. They may be med-boarded out because of their brain issues, and this is what they wanted to do with their whole life. I have a little guy now, I just love him. He is so thoughtful, and he was med-boarded out, and he sits in my office, and I said, well, what do you think he lost on your tours? He has 3 tours. And he looked down at his shoes, and he thought about it, and he said, myself. He also was med-boarded, he needed a bone transplant in his leg, his marriage fell apart, and of course he wanted to be a career soldier, so he lost everything. So when they come back, they have no place to start. Okay, there's a lot of shame over their poor functioning. There's a lot of misunderstanding of criticism. If there's a tone in your voice or a scowl on your face and you're a supervisor at work and you criticize them, they're going to come right back at you. And that's because they don't mediate things well. They have lost a certain membrane that allows some stuff to stay out and some stuff to get in. I mean, that part of treating is building that back up. And they have very poor impulse control and poor judgment. Now in the workplace, what you're going to see is an inability to maintain attention and easy distraction, that's going to make a job longer. An inability to perform a job at a consistent pace, difficulty getting along with coworkers. There may be a lot of irritability there, or there may be a lot of distance, not talking about what they went through. Somebody might sit in my office for a year, once a week, before they tell me anything. I have them write down everything. I do a tremendous intake. And still, it'll be a year before somebody says, I feel badly about the guy in the blue shirt. And I will know nothing about the guy in the blue shirt. So that begins the conversation. Okay. Some difficulty making work-related decisions, and that is definitely a brain injury. May not be able to sustain an ordinary routine without special supervision. Irritability with coworkers and supervisors, and inability to ask simple questions and ask for help. Exhibiting behavioral extremes. Sometimes it's inappropriate humor, sometimes it's anger, sometimes it's blankness. And then difficulty working in coordination with others, in open space, in certain kinds of light. Veterans never want to sit with their back to the door or to a window, and they don't want to be in a noisy place. And the reason they don't is they're busy, hyper alert, scanning their environment for danger. If you put their back to the door, they can't scan back there. Okay, so what are the interventions? Okay, you can't ask if you're an employer, you can't ask a lot of these questions, but you can certainly ask them as someone who's treating. Okay, and I always try to get a very thorough intake, and in that intake, there are all sorts of things. I want to know, do they have any health problems? And they'll say no. And then I'll get to the medication part, and they'll say, oh, but I take albuterol. And I say, do you have asthma? And they'll say yes. So I have to go back to the first page and put asthma, because they don't think of it as medical. Okay, so asking for their medications also tells you something about their physical status. Okay, now, I asked them if they had any accidents where they hurt their head. Did they fall out of a tree when they were 8? You know, I want to know this, okay. And then I asked them these questions. Have you had any more vehicle accidents? Were you hurt? And if they say yes, I say, did you go to an emergency room? And if they say yes, I say to them, were you admitted to the hospital? Because they will be admitted if they were unstable. So I know it was serious. If they attempted suicide and they went to an emergency room and were admitted, it was a very serious attempt. They almost got there. So this gives me a lot of information. Okay, and then I asked, well, did you have some kind of a scan of your head? And they might not remember, but they might. And I'll say, oh, do you remember what it said? And then I asked them, well, what changed after your accident? Your relationships, work, fatigue, focus, and then I go down that set of medical, cognitive, and emotional changes to see what I can find. Okay, so here's the other thing, is that it's probably 99.99% sure that if they have a head injury, they're going to have PTSD, okay? Because we think of this as where the seat of the self is, and if it's altered, it's one of our biggest fears. Okay, so the very first thing when you see somebody, you do this huge assessment, and then you build a team. Okay, I'm not an MD, so I want an MD, and I want a neurologist. Okay, and I want a neuropsychologist to do testing. I'm not certified to do that. Okay, but I want to see results. And I want a social worker, because I want someone, or a veteran service officer, to get this guy through the system, get what he needs, paid for. I'd like an occupational therapist to help him get back on his feet work-wise. I'd like a speech therapist. I would like a physical therapist to help him regain his balance, or stop falling, or assess for his inner ear to see if he's dizzy. I want a family therapist, because his wife and family are going to require that. Lots of marriages break up over TBIs. Okay, a biofeedback therapist. And the reason I want that is because I want to be able to have the guy sit down with a trained person, and I want that person to hook him up to a machine. And he's very anxious, and the guy says, okay, there's a red light there, turn it blue. And so the guy's sitting here, wired, trying to figure out how to do that. And it's a little like a Zen koan. You cannot figure this out intellectually. You must change the way you're feeling to change that light. Once they know how to do that, they don't need a machine. And then they can help their anxiety level by going from red to blue in their head. Okay? So that's why I want biofeedback. It is using the body as a tool. It's very helpful. I want visual therapy, which has to do with colored glasses. And there are several different colors that are used, and a neurologist can get you to this kind of a person. And like dark blue, which will completely change their visual field and really make it less invasive and provocative, which would be very helpful. This also works with autistic people. I want to send them for body work to a massage therapist or an acupuncturist to see if we can take care of some of the pain that way. I want to send them, if they are using drugs or alcohol, they're going to get detoxed in rehab, because you can't do therapy if they're doing that. And then I will send them off for a service dog. Okay, now before I introduce these two ladies, I just want to talk to you about how the brain heals. And it heals very slowly, years. Okay, and it scars. And when you get a scar in your brain, what happens? Well, you get a scar and it disrupts the electricity that's going through your brain. And that's what thinking is, it's electrical. Okay, so what happens? Well, most of the time, you get seizures, but you can control them with medication. Okay, so that's why you need a neurologist on board. Okay, if you want to learn a skill, whether you've had a brain injury or not, what helps you to learn it is practice. Cells that fire together, wire together. So you practice new things with someone who has a brain injury, a new way of doing something, or an old way, but you have to practice, practice, practice. And you have to organize their day in order to do that, and use a smartphone with alarms. Okay, and routine is really important, so you get them up at the same time, they eat at the same time, they go to work at the same time, they come home at the same time, they go to bed at the same time. That helps them. And you put all that stuff in their phone to alarm and remind them. Ongoing therapy with their family and client, very important. Okay, very clear boundaries at work and very clear boundaries at home. This is okay, this is not okay. You may not yell at me. You may not curse in front of the children. You may not drop your dirty clothes on the floor. Very clear boundaries. And every time the dirty clothes are on the floor, you call John, clothes don't belong there. It's about building those new habits back in. Okay, and then in a job, it would really help if you precepted the guy in. What that is this is how nurses are trained. You know, you go to school, then you decide you're going to go into this aspect, so then you get trained for 6 weeks in the hospital by a specialist of that aspect, and then you get assigned to a nurse, and you follow her around. And first she does everything and you watch. Then you do part. Then you do everything and she watches. And when she feels that you're safe, you're not going to turn the stopcock in the wrong direction. She lets you be and she follows you, and then you get to be on your own. Okay, so a preceptor is not a bad idea. The more complicated the job, the longer the preceptor. Okay, reframing catastrophic reactions. Okay, one of the things that happens with traumatic brain injury and PTSD is a loss of an ability to self-regulate. So that flying off the handle is one of the most common things that people do. And what you have to do is be able to say, you know, drop in that glass and break it, and it's not a big deal. You can't mirror the catastrophic reaction, that'll build it. So you want to back up, put some space there, and psychic space, and say, we can get past this. And what you're doing is modeling problem solving. It works. But it works if you do it over and over and over. Okay, and then if someone's had a brain injury, you avoid drugs, you avoid alcohol, you try not to give them sleeping medications, you try to do other sleep hygiene things. No contact sports. If you have teenagers, don't want to play football. It's a huge mistake. They're getting those concussions over and over, and now we're finding with the NFL that those concussions lead to early forms of dementia. Well, yeah, if you get your head beaten over and over, it's not going to be good. Okay, don't give them caffeine, it's an antidepressant. Nicotine, same. Don't give them complex jobs, they won't be able to do them. Break things down into bits that are you can swallow one at a time. And then angry criticism is a very bad thing, even though the wife may be very angry that this has happened. It's not good to express it to him. Let her come to therapy and express it to the therapist, because that will just undo him. Okay, now I am going to introduce Susan Haney and Judy Braun and Posey, who are from student service. And while I do that, my one thing is I have a donation box. These guys put $25,000 into dogs that are being thrown away and train them to be service dogs and give them to veterans. Okay, they train the veteran, they train the dog. So if anyone would be willing to give something, that would be wonderful. After they're finished, we'll take a break, and then I'll do my new version of PTSD.
Is there an online way to donate money to this?
Yes, freedomservicedogs.org, and we've got some materials in the back, little flyers that has that information on it. Thank you very much.
One of the things when I was working at Mines was the fact that I would often get calls from companies saying, we just hired this veteran, let's come back, and we're having all kinds of problems with him at work. We had one who got blown up by an IED, and it just so happened that there had been some news media there filming when he got hit. So one of the things he wanted to do was he would bring a copy. They actually gave him a copy of this from the news media, and he wanted to bring it to work, and he wanted his fellow employees to see this video. He progressed from there to the point that he actually ended up finally bringing a gun to work, and that was we had worked with him up to that point, and finally they had to let him go because they just couldn't handle what was happening. So I'm sure as more and more of these soldiers are coming home, you're going to get more and more calls about what do I do with this person. You want to hire these veterans, but they're coming back with all kinds of situations. It's their new normal. It's not, their normal is not our normal, so it's very different. So with that, Posey, you want to lay down? Down. Uh-oh. This is Posey, and she is a service dog, and she has been placed once before with a veteran, and unfortunately, her veteran died, and he had a brother that used to check in with him. He lived in an apartment, and his veteran used to check in every day with his brother, so his brother kept an eye on him. And one day, he didn't call his brother, and so it was hours later, and when the brother went over to see what was going on with him, he had died. He was on the floor, and Posey was laying there on top of him, staying with him, hoping to revive him. He was licking him. So Posey came back to us. They returned her to us, and she had lost some of her skills because with a service dog, you have to work with them every day. And so she had lost some of her skills, so we've been retraining her again. Down is not one of her favorite things. That, and she doesn't like to pick up keys because most dogs don't like metal in their mouth. But the good news is she has been placed with another veteran from Colorado Springs. And Susan, you have the information on the new veteran she's going to be placed with.
Yeah, her trainer, Fran, the staff trainer at Freedom, posted this on Facebook just the other day, and just a couple of comments about it. She said, the young man is a veteran with some back and leg injuries along with some major PTSD. He simply lights up when he's around his new girl. She'll do so much for him, sweep a room, and turn on lights before he goes into a room, making him feel more secure and to help prevent flashbacks. So she's trained to scope the room before he walks in there. She will wake him from nightmares, nudge him if he starts to have anxiety in public, stand in front of or behind him as needed, and give him a buffer zone in public, which a lot of veterans want, and the dogs provide that. We train them to do that. Help him sit up in bed, pick up dropped items, except metal keys, and open doors to help with his back injuries. Bring a phone to him if he should fall and have trouble getting up. She's such a smart pup.
Susan, tell them a little bit about service dogs and the regulations around service dogs, and I'll tell them a little bit more about Freedom Service Dogs.
Okay, service dogs are actually service animals. They're service horses as well, but we work with the dogs. Are protected under the laws, I should say. There are federal laws, which is the ADA. You have state laws. Colorado has laws about public access for service animals, and then you may run into them in the county and city level. So, and they don't all coincide. So it's important to, if you have clients who have service dogs, to understand what the laws say and to help them be aware of those as well. And under the federal law, the Americans with Disabilities Act, or ADA, requires that businesses and organizations serving the public must allow people with disabilities to bring their service animals, and that includes those horses, into all areas of the facility where customers are normally allowed to go. And that includes restaurants and hotels, taxis, shuttles, airplanes, and buses. You see dogs, they're on airplanes, in the seat, or on the floor usually, not in the underbelly of the plane. They can go into grocery and department stores, and we take these dogs on outings and walk them by the meat department and make sure that they are not distracted by the lovely smells of the meat counter. Hospitals and medical offices, although I hear they're not allowed in the OR, but they're allowed anywhere else in hospitals. theaters, health clubs, parks, and zoos. So they can, wherever a person can go, the animal ask are, and this is the law, ADA, is the animal a service animal? Yes, no. And what tasks the animal has been trained to perform. So you can ask the person, what has your dog been trained to perform? But you cannot ask about the person's disability, and you cannot require special ID cards for the animal. And so service dogs also do not have to be registered with any agency, which makes it really difficult for people to determine, is this a real service dog, a fake service dog, is it somebody's pet? You know, so that's a very gray area. And I think there's some efforts underway to introduce legislation to tighten this kind of thing up. Also, generally, people with disabilities who use service animals cannot be charged extra fees, be isolated from other patrons, or treated less favorably than other patrons, cannot be asked to remove the service animals unless there's specific issues stated in the law. So if you're at a theater and the dog's barking, of course, that's disturbing, and you can ask in that kind of case that they leave or sit somewhere else or go somewhere else. Allergies and fear of animals are generally not valid reasons for denying access to people with service animals. I actually heard that on a veterans thing where one of the staff is afraid of dogs, and I went, this dog has access, so FYI, we're going to bring him to the event. Violators of the ADA can be required to pay money, damages, and penalties, so just be aware there are penalties. One of the other points is a lot of people think therapy dogs have access under the ADA rules. They do not. Service dogs are more highly trained. Therapy dogs do not have full access in the world, so there's a difference. And as I mentioned, there are serious problems today with fake service dogs owned by people who buy vests on the internet. And you go on the internet, buy a vest, says service dog, poof, off you go. And they try to pass their untrained pets off as service dogs. This is a real problem for the public, and it's in particular a problem for people with true service dogs to get over that perception that, well, are they or aren't they, and it is causing a lot of trouble. So there's a lot of information on the internet about that if you're interested in learning more. And one of the things Freedom Service Dogs does provide, it's an ID card. It's not a certification. This is an example of one. On the back it says Freedom Service Dogs has the address and phone number. It says a full member of Assistance Dogs International, and it certifies that it's a service dog, but it's not required by law that anyone have these. And then it mentions the law, the name of the law. And this says access guaranteed by law. The name of the dog is Bud, which actually was a dog that we trained in, was placed as a veteran. And the service dog is for Bunny Foo-Foo, who's a fake trainer, picture here. And the emergency phone number to call is Ghostbusters, 303-555, whatever. So these IDs do help if the dog gets lost or is misplaced to have them call Freedom, but they're not required. Anyway, of course, Freedom Service Dogs graduates are the best, of course. And we'll show you today with Posey, who's just been matched with her new person, some of the things that she can and will do for her person. So that's pretty much it.
So would it be legal to ask the person where was the service dog trained?
You can do that. And I think, and I've followed I love Freedom and have been affiliated with them a long time. And one of the things that we hear a lot, feedback a lot about service dogs is, what's your disability? I don't see anything. Why do you have a dog? That is so rude. And the person is really confounded on how to answer. And after a while, they just like, I don't have to explain my problem. You can't ask about what their disability is. It could be PTSD, it could be a brain injury, it could be anything. But where I was trained, that's fine.
Freedom Service Dogs was actually founded back in 1987 by Mike and PJ Roche. And Mike was a paramedic, and on one of his calls, his ambulance got T-boned, and he ended up becoming a quadriplegic and having to go over to Craig Hospital. And while he was at Craig, his therapist's name was PJ. And one of the things that he asked PJ to do, in addition to being a trainer or a therapist, she was also a dog trainer. So Mike asked PJ if she would consider training his dog to help him pick up things. And his dog's name was Oreo, and the kids love this. When I go into the schools, I always ask them what color was Oreo, and they always say black and white. So she actually ended up training Oreo, and as a result of that, some of the other clients at Craig Hospital saw what was going on, and so they asked whether or not Mike and PJ would consider training their dogs as well, and they actually did, and that's how Freedom Service Dogs was actually born, and has continued since. Their motto is FSD rescues dogs to free people. We work with mobility impaired, like the soldiers or people in a wheelchair, a lot with the veterans, and as Susan mentioned, when they have PTSD, they don't necessarily look physically as if they have problems. Since 2009, there are 425,000 soldiers that have come back with physical impairments. And Time Inc. just did a couple months ago did an article on the soldiers coming back with PTSD, and there are currently estimated 261,998 soldiers coming back with PTSD. We also work a little bit with children who have autism. So in addition to the veterans, we work with people in the community who are mobility impaired, and then children who have autism and Down syndrome. As you know, with children with autism, they tend to like to wander, and so we tend to use border collies. And again, border collies like to herd, so they're very good at herding the children who to keep them in the house. The one little boy that got one of our border collies, it was one of the first dogs that I trained when I started at Freedom Service, and the dog's name was Pilot. And Pilot went with this little boy because one of the things that was happening, his parents never got to sleep through the night because as he grew, he learned how to open doors and unlock doors, and the neighbors would find them in their refrigerator in the middle of the night and stuff like that. So they trained Pilot to herd him. And one of the interesting things though, Pilot didn't bark. So one of the things we had to do was teach Pilot how to bark so he would warn them what was going on. But Freedom does all of that. The thing that's interesting is all of these dogs come from shelters. So they are, in essence, these are dogs that would be, quote, throwaways. And you see those wonderful ads on TV about all these shelter dogs for adoption. And these are dogs that can do some remarkable things. In addition, we get some from private donations. A lot of them come from prison, and they're trained. You've seen the prison program and the things that the prison program does. They will train, if you go on the prison website, the ones that are marked for FSD actually are being trained, but then they have other dogs that are up for adoption. But they do the basic commands with them, and then when we get them back, they are trained to do the specialty things that they can do. For example, Cozy coming in today opened the doors for me with hitting her paws on the handicap buttons. It takes about 7 to 12 months to train these dogs, and they go through different camp levels in terms of being able to pass different tasks, and there are 5 different levels of placement. And as I said, it takes about 7 to 9 months. It is a nonprofit organization. That's 7 to 9 months. It's about $25,000 to train each dog, and everything is done by grants and donations. So that's always one of the problems. One of the things is we're always looking for room for these dogs. Currently, the location is down off of Santa Fe and Union, and we have room to graduate about 30 dogs each year, and we have currently about 80 soldiers on the list for a service dog. So obviously what we would like to do is to be able to train at least 60 dogs a year. So we have a capital campaign going in order to raise money to build land. We actually acquired land off of Lucin 470, so hopefully to be able to do that. The thing that's interesting is these dogs never go back to the shelter. So if it turns out that they're not okay being a service dog, on the website, there is an icon you can go on to see what dogs are up for adoption. And they can be adopted. And what better way to get a dog than to get one that's already been potty trained and can do some things. And so it's wonderful. They never have to go back to the shelter. What we're going to do is to show you some of the kinds of things that Posey can do. She's a very good girl and she's very focused. So I'm going to let Susan do that while I explain.
Come on, Posey. Posey. No, she's
She's-
not your mom anymore.
Yeah, she's very attached to me because
Yeah,
she goes on
they go on
demos with
demos
me
a
all
lot,
the
so.
time. One of the very first things we do is to teach them their name. And we use
Watch.
positive reinforcement,
Good
so
job.
everything is done with treats.
And we want them to watch us and be focused on us so that whatever we're interacting with them about, they're not looking around or doing all that. So that's one of the first things we teach them. Down, Fuzzy. Good. Down. Fuzzy, stay down. Fuzzy, sit. Now, one of the things we teach them, we got to treat, every time, we use positive reinforcements, every time they do what we want them to do, we click and then treat, so they know that that's the preferred behavior. We don't scream at them as much as we want to when they're running that way, and we want them to come this way. You have to sound happy and please come see me. So it's all this positive, like we do with people, you know. I'm gonna do an under or two.
When we go into restaurants, obviously, they have to
Fuzzy.
be able to stay. You notice she stayed
Under.
under the table really nicely. So that's, we do it under. And then the other thing that she's taught is a command called leave it. Obviously, we don't want her eating what's on
Fuzzy,
the
sit.
floor. So she is taught,
Wait.
they didn't feed her this morning, by the way, so she's especially
Now, see if
hungry.
this works.
So,
Fuzzy, come. Leave it. Good job.
so she will not.
Fuzzy, leave it.
So you'll see she's not eating anything off the floor.
Sit.
And when we train, when we pick those things up, we don't obviously let her have those, so they get put away.
Well, what we can do, and I don't know if Fuzzy knows how to do this, can you put it on her paw and tell her to leave it? Does she know that one?
I don't think so.
I don't know if she'll make that one. We do teach some dogs, put the treat right on their paw and tell them to leave it, and they won't eat it. That takes a long time to train them to do that. It's so cool to show it. So.
We teach them to open and close refrigerator doors and dryer doors.
Fuzzy, that wasn't very nice. Sweet little sneak. And I know you're hungry, baby. Just a minute.
So we do what's called a tug. We use the tug and tie it onto the doors of the refrigerator. They can take water bottles out. In the dryer, they can take the clothes out of the dryer.
Good tug. Let's do it again. Fuzzy. Tug. Fuzzy. Give.
That's the other thing, we teach them to pick up their
If
leashes.
somebody's in a wheelchair, for example, or they're wearing a prosthetic and they drop the leash, they can teach them to take. Thank you.
And then, of course, a lot of the things are retrieving for people who cannot get down and pick things up for themselves.
So you've got some other things there. Okay, so we're going shopping and I have to do this credit card thing. Fuzzy. Thank you. Good, thank you. Fuzzy, wait. And then after a while, they know, they get a treat if they do this. Peg, bring. Good job. I didn't even have to tell her that.
That is actually 3 commands. There's a take and a bring and a give. So we teach them 3 different commands.
The first demonstration I saw of one of these dogs, the woman was in a wheelchair, and she dropped a dime on the floor, and the dog picked it up and brought it out and put her tongue out and handed her the
We actually, some of them, and not all dogs do everything. As we said, Posey's been taught to pull her client up
Fuzzy, sit.
and things like that, but they're not all taught to do the same things, but we
Fuzzy,
do
take.
have some. I don't know that she'll, I don't know that she'll pick
Fuzzy.
that up.
Yeah, some dogs will pick up coins. I don't think Fuzzy likes
She's
that.
bringing, and her leash is a big one if they're in a wheelchair, because obviously, we want them to be able to do
Will
that.
she do the phone?
Yeah, she'll do the phone, I think.
Sit. Okay. Fuzzy, take. Good job. Just take.
She can't take it.
Come
Just try.
Take. Okay, you try. We won't belabor it, but a few minutes she can do that. so.
For the soldiers who have PTSD, obviously when they go into places where there are more people, they are very cautious. As Susan mentioned, they want their backs to the wall, and so some of the things we teach them are things like front.
All right,
Can you do a front for them, Susan?
Come here. Cozy, cozy, front.
So that they would sit between the people and that.
Here, front. Cozy, front. Just where's my treat?
Also, back is another one.
Cozy back. Here. Cozy back. Good back.
We teach them to go back in case they're in the way. We teach them move, come on, move.
Cozy, cozy, move. Cozy, come on, move. Cozy, move. It means to get out of the way, so she's doing a little bit of that. Back means like if you're in a doorway or a hallway and you need to back up, you're in a wheelchair, that's straight back. This is move the other way.
We teach them to pull wheelchairs. We also teach them to take off socks and shoes if the client is unable to do that. And as Susan mentioned, Posey's been taught to pull her client up into a sitting position from a reclining position. He's not able to do that. So those are some of the different kinds of things. And you can see she's pretty willing and able to work. You notice she didn't bark the whole time, and she stays nicely. And I know we had that therapy dog that was here and was kind of all over the place when we had the woman doing that, but she will stay very well.
Let's try the keys.
So, any questions that you have for us about the service dogs or the soldiers? Yes.
Thank you.
I have a couple questions, or
Okay.
actually 3 questions.
Okay.
Why do they always have signs, "Don't touch"? Is that to not interfere with their service?
Exactly.
Or is that because of the relationship with the person, or?
It's a combination. When they're working, when she has her vest on, she knows she's not supposed to. A couple of you had asked, can I pet her? So the command when she's allowed to be petted is, I tell her she can visit. And if I tell her she can visit, she's allowed to come over to you. Otherwise, we want her to stay. Our shirts that we wear when we train said, what do they say?
Please don't.
Please don't touch me, I'm working, and things like that.
And what do the dogs do for exercise?
They,
Or do they not?
Oh, no, they get exercised. When they're at Freedom, in our kennels, they get exercised at least twice a day. They have morning play group, afternoon, and there's a whole group of them that do that. We have people that come in and walk the dogs during the day. On Tuesdays and Thursdays, Susan and I go in and work and train the dogs. We go on outings with them, so we keep them very visible. Then there are people who foster the dogs, so the dogs get taken home on weekends and holidays. So if you would like to do some of that kind of thing, if you'd like to foster a dog, take a dog home for a weekend, if you want to come in and walk them, they're always looking for volunteers. We brought some postcards. Please go on the website and take a look at all the different kinds of things you could do as a volunteer to help.
And in answer to your question, these dogs are working dogs, that's why they're protected under the law as service dogs, so it's important not to go up and interfere with what they are doing for their person. They do have time to be regular dogs, like off duty, but when they're out with their person, they really cannot be interfered with, so it's always important to ask. And don't be offended if somebody says, no, please don't. Go away. So, just to add to that.
Yeah.
So what about the breeds or the mix of breeds that
Good
are
question.
work
Yes.
best for this purpose?
The breeds that we look for primarily are labs, yellow, black, chocolate, golden retrievers, standard poodles, because they're very, very bright. Obviously, most of what we get are mixes. Once in a while, we get private donations. We had 2 poodles that we just graduated that were standard poodles. And of course, Posey is
don't even remember what happened. I had a pilot, and I said to him, he was a very up guy, and I said, well, you were a pilot in Vietnam. What do you flew fixed wing aircraft? I said, well, what do you remember? Nothing. Absolutely nothing. I just love flying. Months later, he brings me this piece of paper. He said, I forgot to tell you. I crashed. He crashed in the ocean. And he crashed in a plane that was on fire because he wanted to get far enough out in the ocean that he wouldn't get captured when the tide brought him in. He didn't remember. And then it was no big deal, I might add. Okay, so they avoid people, they avoid places, they avoid thinking, they avoid conversations. And then there is this inability to recall some important aspect of the trauma. I have this gentleman now, he's back from Iraq, and he was telling me about going on convoys and house to house, and he neglected to mention he killed a 6-year-old, ran him over. Okay, why did he run him over? By the way, I don't judge. Okay, just tell me what happened. Well, this kid was being used to stop convoys when they made the ambush. So your choice was run over the kid or lose your guys. It's not much of a choice. So when you put somebody who was raised with mom, the flag and apple pie, and goes to high school and has ethics and morals, and you put them in a place like that, of course they're going to be changed. How could they not be changed? Okay, the hyperarousal means they are going to have trouble sleeping, and they all have trouble sleeping. Then they get irritable because they're tired, and they have difficulty concentrating, and so they fail at work, and then they have an exaggerated startle response. All of my veterans sit in exactly the same place on my couch, facing the door, and my door jiggles a little when the door downstairs to the outside opens and closes. They jump 3 feet off that couch. I don't say anything, but I know it. Okay, now PTSD causes real trouble in marriages. People start avoiding things and doing things to be safe that their spouse cannot understand. And it's difficulty with working, and it's difficult in just social places. It's a huge impairment. Okay, now if you read the DSM-4 and 5, you can diagnose this as acute, which means the signs and symptoms occurred less than 3 months after the incident, as if there were one, and or chronic, more than 3 months. Or you can have, and I have this with several of my Vietnam guys, with delayed onset. The average of my Vietnam guys came back for about 13 years. They drugged, they doped, they got into trouble with the police, they had several marriages, many children, and finally realized they didn't die. And stopped. Got clean, got sober, and are now very ill because of their lifestyle. But I would like to see that we have a better way of reintegrating our veterans than that. And those guys came back from a very unpopular war and were spit on when they came back. So they got out of those uniforms and never admitted anything. Okay, well, what does that tell you? Now, for women, women are much more likely to be raped and shot in the service. And military sexual trauma includes both men and women, and it includes attempted and or completed sexual harassment or assault. Harassment among women veterans is 55 to 70%. Really high. And the reason it's so high is because who does the harassing? The commanding officer. So where do you go? Well, there are now places to go, but people who are downrange, not so much. You can go to JAG, but that's going to be a problem. Just like if you go and you report to the psychologist or the social worker downrange that you have PTSD, that could wreck your whole military career. You'll get a psych will be on there, and you might not get promoted if that's what you want to do. Okay, sexual assault among women veterans, 11 to 48%. And it's probably higher because I don't think everybody reports. Okay, now when I did this talk before, what I told you was that there was an average of 5 U.S. soldiers attempting suicide every day. It's 22 now, which means that in 1 month, that's 660. Do you hear about all of them? No. If you would like to know a little bit more about that, you should read Thank You for Your Service. It's a very black book. You should also read The Yellow Birds. And this book which is called The Things They Cannot Say, Stories Soldiers Won't Tell You About What They've Seen, Done, or Failed to Do in War. You should read stuff like that. Okay, so what can I tell you about how to treat these guys? Okay, well, safety is the big focus, and that's because they are unsafe. They feel unsafe, there's no safe space for them, and certainly a door at their back or a window at their back is not going to be safe. Somebody or a thing can come in. I have a guy who's driving his truck home, this happened last year, he's a Vietnam vet. He was in Denver, and he saw a guy in a black shirt and black pajamas, and he was crouched on a bus bench, and he thought, that's a good home. I thought, I'll just empty my truck out. And then, of course, realized that wasn't so good and didn't do it. But he says that if he's in the market and he hears Vietnamese spoken, he has to leave. He feels so unsafe. We're 50 years ago this happened. The guys from World War II, they never got treatment. They will go to their deaths with this stuff on board. They came back and they were supposed to get jobs and raise their families, and they didn't talk about it. I've got a 94-year-old father who still has nightmares. Okay, so symptom management is something you want to try to do, and assist with family therapy or marriage therapy in personal functioning. And a lot of times what these guys have lost is the capacity for empathy. And that was something that if they were going to kill somebody, they couldn't be feeling for them. They had, and in boot camp, they're gooks, slowheads, they aren't human. That's how can you can kill them.
Isn't that part of the problem, though, before you even get into battle? We train people to hate people so
Train
they
people to
can kill
hate
them.
people, right. Well, you know, we do that at home too. It's not even in boot camp. It happens everywhere. It's something we need to pay attention to. Now here are the categories, and in the notes online you can read about these categories, and I'm not going to tell you about them. I'm going someplace else. You can do psychoeducation, and I always do that. Okay, I explain, look, you've got this. I don't think of it as a mental disorder. We're going to treat it this way. We're going to write a care plan together. You are going to end up writing day by day everything you can remember that happened to you and that you did, and you're going to talk about it, maybe many times. Okay, so psychoeducation isn't enough. You can do cognitive behavioral therapy with them and try to change the way they think. You can do EMDR, which has a lot of research behind it. Here's the problem, it's going out of fashion, and that's because what I'm hearing is, oh yeah, I had that at the VA, it didn't work. Or it worked for a week, which means it didn't work. Virtual reality, that's putting them back into the combat zone, but with a lot of equipment on them, and then you introduce explosions. I mean, this time you let them not get wounded, you let them win the gunfight. You can do stress inoculation, you can do group therapy, you can do family therapy, you can do narrative therapy, and I'm coming back to that. Self-help groups, you have to get them detoxed and rehab. And it is so easy to get alcohol. They don't need a doctor, they don't need a script, it's open all night, and you know, they can just muffle everything. And it's one of the things I won't, you know, I'll set that as a goal, and this number of weeks you have to be clean and sober. If they don't meet that, they can't see me. It's very important because they can't do the work. Sometimes they can't even remember. Okay, so then there is, let's see, a family empowerment therapy. There is a strength-based intervention component to it, and there is a military child education coalition if there are children of veterans you have to deal with. There's a student-to-student program where children of veterans help children of veterans in the school. And there's a comprehensive soldier fitness program, and I wish I had thought of this. Three very famous psychologists sold the Army what I think is a bill of goods, which is we can do a test called a GAT and look at certain dimensions of a person's life, and we can tell where they're weak, and then we'll train them on a computer, and we will have a PTSD resilient soldier. Okay? You want to think that? So, I don't think that. I don't think you can do that. So let me tell you what I think, okay? Which is, that I think it's not a disorder, that I think it's a response to trauma, that I'm an analyst, okay? I'm not a Freudian analyst, but I'm an analyst. And in my training, I sit and listen to people for a very long time. I do speak, I'm not silent. But people are hardwired to tell stories. And the story we tell about ourselves is our life history. And what I think trauma does is it disrupts neurological and psychological functioning. And I want to read this little piece to you. And this is from a book called Achilles in Vietnam by a guy named Dr. Jonathan Shea. And it says, to encounter radical evil is to make one forever different from the trusting, normal person who wraps the rightness of social order around himself, snugly like a cloak of safety. When a survivor of prolonged trauma loses all sense of meaningful personal narrative, this may result in contaminated identity. And I wouldn't use contaminated, I think I would say broken. Okay, so the VA is doing some basic research at this point, and I would roll my eyes yet again. They are working, it's basic, so we're talking ransom. Okay? And what they're doing is they think they can break the linkage between trauma, which is just about fear in the brain, and long-term memory, and they think they can give you a drug to snort that will break that linkage. So they're going to give it to everybody who's going to go overseas in a war, so that if you go downrange, you won't have PTSD when you come back. Well, my feeling about that, since I see a lot of Agent Orange veterans, is prove to me that in 25 years, after they sniff that stuff, their brain's going to be okay. Then let them sniff it. Sorry, not happening. So does the brain function that simply anyway? And is the rat brain a good model for the human brain? Because we know that this little 3-pound thing is very complicated. One of the latest pieces of research on sleep is that your brain cleans itself and gets rid of cellular detritus at night, which is why people who don't sleep don't do well. Okay, so I want to know how to treat PTSD. This is the way I go about it. And Walter Wright, you gather a team just like you do with a traumatic brain injury, and you do eventually involve the family. And you go through a very, very labor-intensive, I can do it in 45 minutes because I'm used to it. I have a form, I go down with all my questions on it. And you find out about drug and alcohol use that affects PTSD. Any other kind of addiction, street drugs, heroin, whatever, sex, gambling. You find out about suicidal and homicidal thoughts. You find out if they were attempted it, what happened when they did, what did they do. The more like putting their head in the oven when they were 13 is very lethal, okay? So you go by lethality and you try to figure out, okay, if they try that then, God knows what they'll try now. And does a suicidal contract work with clients? No. Should you do it anyway? Oh yeah. And you should also rate on a scale of 1 to 10. This is just now to cover your tail feathers. If you should have like 1 to 3 is not very suicidal. 3 to 6 you should do something about, and 7 to 10 they may need to be hospitalized. And as they get better, you should re-rate them during the course of treatment. Okay, do they have weapons in the house? If they're suicidal or homicidal and they have weapons in the house, you have to get the weapons secured and the key given to the neighbor. Okay, you have to evaluate for comorbidity, depression, anxiety, readjustment, or adjustment disorder. You have to make sure they're sleeping, eating, exercising, and many of them won't do any of those things right, and they'll just eat junk, which isn't good for them. And do they have a history of child abuse? Do they have a history of domestic violence? Do they have a history of elder abuse? Because that's a red flag for, could happen again. Okay. And then I sit down and write a care plan with them. It's a 1-page form. It has 3 short-term goals, 3 long-term goals, and 5 interventions. And I have them sign it. We write it down. We put dates for when stuff should be done. Those dates don't matter. You know, I don't know. I don't foretell the future. I don't know. But we put dates, and we go back and revisit it. And it sends us in a direction that's very useful. Okay, so trauma disrupts a person's narrative. And medical trauma, by the way, you know, I have a woman who just had a double mastectomy, and she was doing well for about 4 days. She was home, she was post-op, she was going to physical therapy, and then she started getting this terrible Okay, when you're in a trauma, you cannot see out of it. Can't see the edges, okay? That's the disruption of the narrative. If you want to reconstruct the narrative, what you have to do is move that trauma from in here to there, 1 inch out, okay? And the way you do that, Freud was right about this, not about a lot of other stuff, but about this, that what therapy does is it takes his word process and moves it from intrapsychic, stuck in here, where the narrative breaks, to interpersonal depression. That would be a good thing. If it's interpersonal, you can work on it. And you can talk about it. And you can walk around something. And it changes as you get older in your lifespan. We don't take away memory. That is not our job. What we do is change meaning. That is our job. And it will change if you let it. All of the symptoms of PTSD are self-protective mechanisms, but they don't ultimately allow growth and maturity beyond the trauma. So opening up a trauma, remembering the details, writing it down, talking about it, and putting it in the interpersonal space. And the way you do that is by saying, well, how are you feeling? Tell me about this. And then you say, well, how are you feeling? What were you feeling at the time? So I had a special forces guy. I saw him for about a year. He was very, one day I walked in my waiting room and he had his back to the door, very mean. He was standing there reading a magazine. And I said, Andy, do you trust me? He said, hell no. I could kill you with a pencil. And of course, the first thing I thought was, are there pencils on the desk? And then he reached in his pocket and he said, I brought you some Russian chocolate. And I said, stay away, but come closer. Okay, so what you want to do, oh, let me tell you the rest of Andy's story. It was really interesting. He couldn't tell me where he was. I knew he had been in some places he wasn't supposed to be in, done some things that he wasn't supposed to do, and at least tested. And about the end of the year, he said, you know, there's one thing I haven't told you, and I feel really bad about it. By the way, he was an assassin. So I thought, he probably had plenty of things. He said that it was a guy in a blue shirt. What guy in a blue shirt? You didn't tell me about that in a blue shirt. He said, well, I killed him. I said, okay. He said, but he never saw me. I said, well, that was the job, right? Okay, I'm on very shaky ground now, and here's the shaky ground. If you haven't read Anna Arendt, The Banality of Evil, and she's talking about the Eichmann trial and the Nuremberg trials, he said, it was my job, I just do my job. Okay, so I know that. And I'm listening to this guy saying, I just do my job. And I said, well, was he a bad guy? Yeah. But I feel bad he didn't see me. And then he said, and this is the one you gotta be prepared for, what do you think? Okay, now he's not asking for a judgment. He's not asking for something moral or ethical. He wants to know what you think. Okay, so what I was thinking was that he felt quite bad about this, but how unusual was that, because there were all of these others. And that, given what he needed to do, I am glad he didn't hesitate, because he could have been killed. That took care of it. Okay, you have to let the patient suffering in. You don't have to let it disable you, but you have to let it in. And that means you're going to get secondary PTSD, and that means you're going to need to see somebody, or you're going to need to meet in a group and detox some of this stuff out. Please do that. Take good care of yourselves. This is tough work. We're working not just now to stop a memory from wrecking a person's life. We're trying to reorient them, reconstruct the narrative with them so that they can go on and have a good life, and have children and all the things they want. One of the things you must not do is to put people in situations or circumstances by your questions that they cannot tolerate. Okay, they will be very polite, they will never come back, and then they won't get treatment. And you cannot cure this. Don't even try, but you can manage it. Okay? I asked my father, he was in the Battle of the Bulge, he was a tank commander. And I said, Dad, you know, this is something as a psychologist you'd never do, but as a daughter I got to do it. I said, Dad, so what was it like? And you know, he did that. What was it like? Did you clear any towns? Yeah. And I knew it was a great big Sherman tank, so clearing towns meant blowing them up. And I said, were you ever boots on the ground? Oh yeah. So what'd you do? Cleared houses. I said, well, could you tell me about clearing houses? I said, did they shoot at you? Oh yeah. Did you shoot at them? No. He said, one time, I was going into a house, and in the basement there were Germans, and they fired on me. So the next time I went into a house, I put a grenade down first. That was his answer. Well, I'm sort of glad he did, because he's my dad, you know, but you understand that when he's telling me this, he feels quite conflicted. Okay, now I want to tell you one more thing, and that's about Project Sanctuary, and then I'll go into the workplace. You know what Project Sanctuary is? Okay, if not, you need to go online, Google it, and what you'll find out is that this is a ranch up in Granby, where veterans can go with their family for a week. There are therapists, they will be fed, they will be given gas cards to get there. It doesn't cost them anything, and they get therapists, family therapists, couples therapists, individual therapists. Their children get to play with each other. They can go hiking, they can go horseback riding, they can go swimming, and it is all about relief for them. And it's really something, all that they gotta do is call, they get a little telephone interview, they get on the list, and when the name comes up, they call and say, would you like to come? If the guy says, no, my mother's dying, they put him back on the list, and they call him again, okay? And it's free. So this is a really good thing. Okay, veterans are very well trained, and they are very respectful of rules and hard workers, so they make good employees. However, with extended and multiple deployments, jobs have disappeared. With the economy downturn, jobs have disappeared, and once a vet returns home, he loses something he never needs again, which is Band of Brothers. And if you haven't watched that movie, watch it. All 10 discs, watch it. It's wonderful. And it is exactly what they lose, okay? And then PTSD makes them irritable. And job complexity makes it worse. And they get into arguments, and they lose their jobs. Or they do something inappropriate, and they lose their job. So they need good, very good ways of thinking about things before they do them. So one of the things that they had to lose, they see a gun coming towards them, they shoot. They see a car coming towards the wire, it's coming 60 miles an hour, they're calling halt, 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 it isn't, they shoot. Okay? They don't want their guys killed. So, okay, what that little piece that we have, they don't have is, let me take a minute and think about this. What would be the outcome of this? That's what you try to get them back. Well, if you did that, what do you think of the guy? What would happen? What would your wife think? What would your boss, you know? You role play it with them, and you give them that piece back as often as you can, because they need it. In this society, they need it. They can't just act on impulse. Okay, I'm all done. Questions? Okay, I'll probably lose my license without, yes.
Thank you for a great presentation.
Sure.
I'm curious where you got your suicide stats, because that's something I've found hard to find.
Oh, you know what? Give me your name and number, and I will send you a reference. The VA has a, by the way, I'm no friend of the VA. Okay, if you try to like collaborate with them, they won't call you back. It's very irritating. But they have someone who worked in another VA out here in Denver wrote a whole book on tracking veteran suicide, from potential suicide from the first session all the way through a number of sessions. I will send you that reference, because that would be a good thing for you to have. I have been, knock on wood, very lucky, and that's also because when I start to worry about somebody, I pick up the phone and call them. And, you know, at 2 o'clock in the morning, I'll meet in my office. It's better
The
than
latest stats I could ever find was 2009.
Yeah.
They weren't very.
Well, and the Army doesn't want, the Department of Veterans Affairs in the Army doesn't want you to know. You know, who would send their kid into battle if they thought that there was this huge percentage of guys that come back and commit suicide? You know, there's a lot of politics under all this stuff, and unfortunately, it comes into play. But give me your name,
Okay.
and I'll,
much.